here today to present this case. I present to you Durgesh, who is an 11-year-old male child who originates from Uttar Pradesh and belongs to the lower socio-economic status of politically modified Islamic classification. And he was brought by his parents for complaints of loose discoloration of skin and mucous membrane since 1 month, and fatigue since 15 days, inability to speak in complete sentences since the time he was born. He has had this 11-year-old boy was very low birth weight at the time he was born, and he had sustained hypoxic insult and required resuscitation and prolonged neonatal care. Since then, he has had significant speech delays. His childhood also saw him getting recurrently admitted to the hospital for fever and cough, requiring IV antibiotics and inhalations. His mother says that he used to complain of easy fatigability and could not play as much as his peers, but that had reduced since the last 1 month at the same time that of the onset of cyanosis. The mother also says that he was always shorter than his peers throughout his childhood. And all these symptoms, the easy fatigability and recurrent hospitalization, haven't occurred after the onset of cyanosis. The cyanosis is seen in both legs and not so much in the hands, as said by the parents. And coming to negative history, he has no history of fever or cough, no history of any neurodeficits, loss of consciousness or convulsions, no history suggestive of events secondary to hyperviscosity or hemostatic abnormalities, and no history suggestive of congestive heart failure. Yes, sir. Before onset of cyanosis, sir.
Cyanosis was noticed since
1 month, sir.
or recently cyanosis was
that more legs, lower limbs.
Yes, sir. And in the lower limbs and not in the upper limbs.
And what are the possibilities you think of history?
Sir, history-wise, yes, sir. So, typically, when a child has recurrent respiratory tract infection, it's because of increased pulmonary blood flow and a congenital heart disease, and also his
What's the name? Left to right shunts.
Yes, sir, left to right, all the left to right shunts, and the history is typically suggestive of them having recurrent hospitalizations until a certain point, and then they develop cyanosis, and the mother says that the symptoms have improved, but that is actually not true, sir. They are actually clinically deteriorating.
What is the definition of recurrent respiratory?
So it's more than 6 episodes requiring IV antibiotics or inhalation agents and hospitalizations in a year, more than 1 in a month, or more than 3 in 6 months.
What is the cause for recurrent respiratory tract infection in lesion?
So, okay, so there are many causes. Lower respiratory tract infection.
Indian Academy of Pediatrics has recently revised the recurrent respiratory tract infection. This is actually with reference to macronide antibiotics.
Yes.
But even in children, they have divided it, I think, to below 3 years and above 3 years. There is no need of IV antibiotic nowadays. They don't give IV antibiotic. And below 3, I think, 6 or something. So that is the IAP definition. It is common. IAP, you can see. It is correct definition. They have adopted it. There's some fact called PCM.
There are some pediatric pages. You can get that. Govind.
Previously started 6 months.
Arun Golden.
Definition of recurrent disfigurement. Please.
More than 2 episodes in a period. More than 2 episodes of lower respiratory tract infection, which is defined by increase in the like subcostal retractions, increased work of breathing. Subcostal retractions and increased work of breathing points towards lower respiratory tract infection requiring hospitalization 2 in 1 year.
So there will be definition of recurrent
What
disfigurement.
is the reference? So the reference on this one? Pediatric textbooks is good. Which textbook? I'll give you the reference.
Yeah, because this is a very commonly
So
asked
6 was
question. It's a very
6 was what previously we used
IHP
to.
had given
This I think is probably
2013 or something, but somebody was what IHP site?
Now, can you tell us what are the causes of how this respiratory infection happens
Yes.
in patients with hepatitis?
So in patients with left or right shunt, there is a increased pressure and volume on the pulmonary vasculature. This causes the bronchioles, the pulmonary arterioles which are dilated to compress on the bronchioles and cause infection. And this causes stasis of mucus and doesn't allow the mucus to get cleared, sir. And therefore they are more prone to get infected. The static mucus. The second is there is goblet cell hyperplasia, sir. And third is because of the coronary heart disease itself, they are in a catabolic state and because of failure to thrive, their immunity is not as good as the rest of the children.
Any other explanation? Apart from these three? You both
Because of increased congestion, lymphatic stasis, reduced fragments of bacteria and everything.
increased pulmonary congestion and arteriolar dilatation causing compression of the bronchiole and stasis, and that leads to infection, stasis of the mucus and also goblet cell disease. Third is the immunity is also less because of the How do you diagnose congestion heart in a patient in a child?
Yes, sir. That signs, sir, or yes, sir, tachycardia, age adjusted, and then we see the respiratory rate. They have increased work of breathing. Their JDP will be elevated. Oh, sir, my child. So increased work of breathing and SpO2 will reduce, and the pulse pressure will be very narrow, sir.
They will have facial puffiness
Facial puffiness, yes.
and also edema.
Depending on
Mother will notice that the child is not taking time.
yes, sir.
Child is not taking
Yes.
Breathing difficulties and failure to drive.
These are
Yes.
two parts. What are the So, this child is now 11 years old,
Yes.
and from the childhood itself, patient had recurrent respiratory infection, and now the mother has noticed sinuses. What are these other possibilities?
So he was not acyanotic till now, sir. So we have to look at all the acyanotic congenital heart diseases with left to right shunts like ASD, VSD and PDA, but usually ASD doesn't present so early in life unless they're very large, and it doesn't get Eisenmenger so early, sir. VSD also later in, ASD is in the third to fourth decade, and VSD is also in around the second decade. second to third, and PDA is around 19 years of age, mean. So it most likely might be PDA.
First year, first decade, which left atrium becomes pregnant.
Either a large PDA or a large VSD, sir.
No, I was questioning that which condition give rise to Eisenmenger very early? Which conditions
Yes, sir.
give rise to student age as reversal stand early?
So PDA is most
And maybe PDA what else?
VS.
Everything else is it. Everything else very comfort. Do that thing. See, we know there in the book mentioned that increased permanent blood flow sinuses because large PP in the sinus are obvious. Understand? And you know, if you can get to feel, no, there is a transposition, usually, inevitably, in the absence of these, you will concentrate only sinuses. Very early in the first decade, first decade.
Yes, sir. In first few days of life, TGA, HLHS, single ventricle and tongueless. But at this age or at 1 year of age, sir, either a large VSD or a PDA, sir.
AP window.
AP window, yes. Post 26.
Why large VSD patients develop early hypertension?
Sir, the pressures between the RV and the LV are the same. It acts like a single ventricle, and there is increased volume and non-restrictive VSD, and there is increased volume and pressure on the pulmonary
Pressure overload
on the pulmonary circulation. And this causes first for the pulmonary pressures to increase, and then there is also remodeling, sir, which occurs.
See, the pulmonary circulation is subjected to a high RV pressure from the beginning. It will never allow the pulmonary artery pressure to come
Yes, sir.
down.
Postnatally, yes, sir.
After birth, normally you expect
Yes, sir, for it to regress. But in cases of VSD and PDA,
large VSD.
in cases of large VSD and PDA, the pulmonary vascular resistance never regresses to the normal. Sir.
Anything in the morphology of the arteriole?
Yes, sir. The arterioles will be hypertrophy and the smooth muscle hypertrophy, sir. There is according to a classification which can be done on biopsy, sir. And
Normal involution will not happen.
yes, sir.
Understand? Normal involution of the pulmonary arteriole doesn't happen. They continue to have it. And hypertensive arteriole pulmonary artery. They continue to have it.
Yes.
What are the factors responsible for progression of pulmonary artery pressure or pulmonary hypertension? Which is the resting participants. What factors?
Yes, sir.
Whatever he has asked is there.
Yes, sir. So
In addition,
when the baby is
so only name the factors. One,
there are
already done
post-run. Yes, sir.
so. Two, then what else?
So
What is pulmonary
when the baby is born, there is increased SaO2, sir, which causes the pulmonary arterioles to dilate, and that's how it.
Oh,
And then there are prostaglandins that.
pulmonary artery pressure.
Yes, sir.
What is another one which is responsible, which causes post tricuspid to occur early, but it will not cause the pre-tricuspid. What is the third question? Pulmonary venous
Yes,
pressure.
sir.
Because the last is hypoxia or SaO2.
SaO2.
And of course, other physiological factors like what?
Yes.
Why pulmonary venous pressure is because of the AV dysfunction. AV dysfunction of course. Load their lipids on very weak volume of the weight, very dysfunction of the stillness very weak and handle volume, very dysfunction of the regular rises, pulmonary pressure rises, then pulmonary input pressure and volume plus pulmonary venous pressure. They are not. So pulmonary actually happened early in this case.
The only book which we need to, because we may have time to read without the development of pulmonary. Also, you can get hold of old Annada, only for the traveler column, which says that we, that also you can read, just for the sake of.
Yes.
What do you mean by non-restrictive?
So non-restrictive VSDs are those is a large VSD, in which there is no pressure, there is no great pressure difference between the RV and the LV, so they act as a single ventricle, sir.
No, that's not right. See, suppose the pulmonary is there, pulmonary stenosis. So in the French small video of the RV is miracle.
In the absence of RV.
In the RV, in the absence of RV.
So see, if you outer they no gradient, isn't it? So which side should be minimum equal to outer annual side. So that LV RV pressure will be equal.
Yes, sir. You can grade it according to the aortic annulus size, with more than 25%, up to 50%, and more than 75%.
What are the in moderate size VSDs can they develop in so big?
Yes, sir, they can develop. Yes, sir, later than the large VSDs. At a later date than the larger VSDs, and it will be in the around the second decade, sir.
Can VSDs develop in application?
Yes, sir.
What age?
Third to fourth decade, sir. 35
Why
years.
it is delayed there?
Sir, when there is a shunt between from the right atrium to the left atrium, there are two chambers that are accepting the blood from the right atrium, sir, because of the defect. So there is not that much of a overload on any one chamber.
Pulmonary circulation is not exposed to
Great
high pressure. It's a volume of.
Yes.
No, what happens actually, the left right shunt depends in ASD RV complex. So from a newborn RV complex is very less below the right hypertrophy because RV pressure is almost equal to relevant pressure, but pulmonary system pressure is equal to system pressure, pulmonary artery pressure. So RV takes time to, develop the more compliance.
Yes.
So that takes months to develop. So before that time, the evolution occurs in pulmonary circuit. So pulmonary surface is too product. So when the left right shunt occurs, the pulmonary vasculature can accept large volume of blood. So then your pulmonary circuit product is involuted. So that's why the PA pressure doesn't rise much early. It takes time. Understand? If you develop it because of internal hyperplasia, vascular hyperplasia more common with the British practice shunt, so the internal hyperplasia more common with
Yes, sir.
Now we have the atrial regulators, they are convinced that there is no Eisenmenger in ASD. They are convinced, they say that pulmonary artery hypertension does not occur. When it occurs, it is inherited, co-inherited. Along with that, and what happens really is a right left shunt across the PFO or ASD, primarily, but then there are cases we have seen also. This is the concept which they are still thinking. When our study, they clearly said that pulmonary artery hypertension is actually basically primary pulmonary artery hypertension which is there.
No, for history, what they show the science more is more than, but the diagnosis from history.
So, differential cyanosis with cyanosis more of the lower bilateral lower limbs and sparing the upper limbs is PDA with isomerization, sir. Sir, AP window present, it would have presented sooner.
Cyanosis?
Will be involving one limb, sir. Right upper.
No.
Sorry, left upper limb, it will spare the right upper limb.
No, uniform.
Even PDA can have uniform.
Yes.
Any other question?
Patient was examined in a supine position when he was lying comfortably in the ward at 30 degrees of elevation. The pulse rate was 86 beats per minute, normal volume, regular, normal volume, normal character, no delay, deficits, and all the peripheral pulses were well felt, sir. And the BP, there was BP was checked in all 4 limbs, and there was a significant reduction in the BP in the left upper limb.
What is the BP?
Left upper limb BP 90 by 60, and the right upper limb was 108 by 92 with a mean of 108. The left lower limb was 155 by 97.
It's going on.
General examination.
We will straight away invite us. Okay, I have a general examination. Okay. He has conjunctival on head-to-toe examination. Conjunctival suffusion was noted. Pectus carinatum. There was no pallor, differential cyanosis in bilateral volumes, and clubbing was also present, grade 3. And
You think in both the upper limb and lower limb or more pronounced in lower limb?
more pronounced in the lower limbs, clubbing. G.
Did you check the saturation?
Yes. Ma'am, that too there was a big variation. In the left upper limb it was 84%, and in the left lower limb it was 86%, but right lower limb. In the upper limb of the left side it was 92%. So on the left upper limb it was 82, and in the right upper limb it was 92.
And what lower limbs, how much?
99 and 86. Sir.
Lower limb, lower limb.
Oh, yes, sir. Sorry. Upper limb was right. Upper limb is 96%, and right lower limb is 86%. Left lower limb is 88%, and right upper limb is 99%. Left upper limb 92% now.
So definitely separation of both lower limb.
You check here, you use one oxymeter or two oxymeters? Two. You must use 2 oximeters. Check simultaneously lower limb and upper limb. Then reverse the oximeter, so that the technical error due to oximeter is abolished and get the same reading. This is very important.
Other thing can check your oxymeter.
Yours also.
But that also can be done, but this is the method described, reversing the oxymeter and trying to eliminate the error in the case. See, the neonatology, they regularly do lower limb, no? Why do they do lower limb?
For PPH.
No, regularly newborn, normal they will do lower limb oxymeter, right? No, as long as ductus is open, the lower limb oximeter will be less. As the ductus closes, saturation of the lower limb will come to the upper. So you know your ductus is closed. That's what this is.
JVP, normal and prominent AAs.
Sorry, so just 1 minute. I'm sorry, I'm still confused about the pressures in the four limbs.
So the left upper limb pressure was 90 by 60, sir.
Left upper limb.
Left upper limb. Right upper limb is 108 by 92. Left lower limb is 155 by 97. And right lower limb is 157 by 97.
One minute. So what sense do we make of it? The lower limbs are being produced at higher pressure,
Yes.
at a much higher pressure,
Right upper limb, yes, sir.
Despite cyanosis,
despite differential cyanosis.
How do you explain lower limb having higher pressure than upper limb?
Exactly.
Then do that and where is the gradient?
Or is it that the patient has bilateral subclavian artery pathology which is narrowing, which is lowering the pressure, in which the central aortic pressure is still high and the limbs are perfused at a low pressure? I mean, this is getting fascinating.
You can't explain that.
So in a normal person also, if you check in the lower limb, you often get a higher reading. How is that possible? Yes, the blood flow across a gradient. I mean, pressure is lower here and high in the lower limbs. How can blood flow from the, say, central aorta and the where subclavians come from there to the lower limbs if the lower end pressure is higher? A very simple answer to this. Anybody from the audience?
It is the peak of the wave.
One second.
Sir, it is the peak of the pulse we are measuring the peaking. That is, peak, as the pulse goes from center to the periphery, the peaking goes up. But actually the area under the curve is lesser this way. So the blood flow is from center to the periphery, not from periphery.
Yeah, so there is a peripheral augmentation of the systolic pressure, and the mean pressure actually is more or less the same. Apart from that, there is an artifact because you use the same cuff which you use on the arm, you use it on the thigh. And when you use an undersized cuff, you will get a higher pressure. So if you do intra-arterial BP monitoring, you will find that the pressures are the same with a slight peripheral augmentation. So this high pressure that you get is an artifact. Even in aortic regurgitation, you do intra-arterial pressure, you do not find that hit sign which is, which we all talk about.
The artery, or tibial, where higher.
Is higher, there's more muscle mass there, so you need a larger cuff also, which you don't tell me.
But still, these are strikingly different pressures.
Correct, so you need to give an explanation. I think what the one explanation he gave, which is probably the most reasonable one.
The size of the cup. The smaller it is.
Or is there a stenosis which you are missing? Could there be enough bilateral subclavian stenosis? You have to keep that in mind.
Yes, sir.
I mean, the more likely is probably the cuff size.
Yes, sir.
Yeah.
There was no radioradial delay or radiofemoral delay.
No, sorry, I can't write an upsize argument because your pressures are lower in the upper limb, right, where arm diameter should be smaller. So,
Yeah, so when you use an undersized cuff, you get a higher pressure. So therefore, you get actually
no,
a
I
higher
doubt whether you
delay.
can push the pressure up to 157. I mean, 157 by what?
Dr. Madhulika.
Okay, I think she is being a little lightheaded. We will not try to give you a hard time. We will just let her think. We can ask some questions to the audience meanwhile. Give us some water to drink if necessary. Make her lie down. So as I was saying, if you do intra-arterial pressures, you get the same. The knee pressure will be the same. But there is a systolic peripheral augmentation of the systolic pressure. Why do you get the systolic augmentation? Yeah, the reflective criteria. So that cost is a little higher. So even when you're trying to do hemodynamic measurements, like you're trying to find out hemodynamically what is the gradient across the aortic valve, for example, and you're using femoral artery versus LV, remember the radius difference. So it's always better to check the femoral artery, LV, intraventricular pressure with catheter will be ascending aorta. So you may think that you need to have two catheters for that. You actually don't. You just use a long sheet of the type that you use for say carotid interventions. So you put a big long sheet and place that in the aortic loop. And through that you put a pigtail or whatever catheter you want, ideally pigtail, making sure that some of the holes are not in the aorta. And then if you measure, you will get a very nice pressure. If you need a pullback, also remember that the pullback should be done rapidly so that some of the holes are not in the aorta and some in the